good evening to you and welcome to this meeting of the Adult Social Care and Health Select Committee. I am Councillor Marwan Al-Naji, the Select Committee Chair. The event is also being streamed live on YouTube, and members of the public and the media are welcome to watch the meeting remotely and listen to the discussion that's been taking place. I would like to welcome all those to the Council chamber and everyone watching on YouTube. I welcome my members of the committee for this evening. Remembering those who lost their lives in the Grenfell Tower fire tragedy, may I ask to have 72 seconds silence, please. Thank you. Thank you. Before we proceed with the meeting, I would like to ask members of the committee to only switch their microphone on when they are called to speak and to turn them off as soon as they have finished. Please remain seated when you are called to speak. Please do not stand up. If a councillor in the chamber wishes to speak on a particular item and has not been called, please raise your hand to draw my attention. Now we move to the agenda of this evening meeting. Item A1, apologies for absence. We received one apology from Councillor Laura Round. Any more apologies? No. Thank you. Item 2, declaration of interest. I confirm that I have no declaration of interest to make regarding any item on the agenda. Do any members of the committee have any interest to declare?
I'm Chair of Health Watch Central West. I'm Chair of Health Watch Central West London, who are reporting today.
Thank you, Christine. Anyone else? No? Okay. Thank you. I turn now to item A3, minutes of the meeting held on the 23rd of September 2021 and on the 15th of December 2021. The minutes of the previous meetings on the 23rd of September and the 15th of December have been circulated. Does the committee agreed for me to sign them off as a acceptable and correct record? Councillor Atkinson.
Chair, I'm sorry, it's the same complaint as last time. There are so many typos and incomplete sentences as to be completely baffling parts of these minutes, and I would ask, perhaps if you haven't got time to check them before they're distributed, perhaps in future you could ask the Vice Chair to look at them. I mean, I'm not someone to be fussy about papers, but as this ends up being the only record of our activities, it needs to be correct.
Okay, thank you, Councillor Atkinson. Anyone else? Yes.
Thank you, Chairman. page 2 of the first minutes, A3, it refers to, I think they haven't updated the heading, because it was the minutes of the 28th of June 2021, which were approved at that meeting,
Yes.
and they haven't updated the heading. It still says April 21.
That's correct.
So the heading should be also 28th of June. The June minutes were approved at that meeting on the 23rd of September. So the April heading is wrong.
Okay,
Thank you.
noted. Thank you, Councillor Spalding. Anyone else on the committee, please, to make any comments? All right, thank you. So these minutes will be looked at, corrected as highlighted, then I will sign them off.
Chair, on questions of content, if you look at the meetings from last time, page 6, the third paragraph down about comments by Councillor Kamali, which is put under public health budget and outcomes, it should really be on other items towards the bottom, because these points were made in reference to questions I raised. I'm happy with the answers given by Councillor Kamali, other than the fact that the most important of the 3 questions I asked, or 3 areas I asked about, hasn't been mentioned. I asked about the hospice, or progress with the hospice at St Charles Hospital. There's no reference to that, and I'm particularly interested in that since the last meeting, Councillor Williams, and I won't steal his thunder on this, has discovered that monies which were given for charitable purposes for the hospice have not been spent and have not been properly accounted for. So I would like our minutes from the last meeting to be amended to take account of the fact that I raised that point, and presumably there is already a recorded version of our events. You can note what was said and what answer was given, and more importantly, I would ask that this council, that this committee looks at what is happening with the hospice and what has happened to the charitable monies that were given for that hospice.
Okay, thank you, Councillor Atkinson. That's observation is noted. It was raised outside the agenda, I believe, last time, and hopefully we can look into this as a committee, and then we'll take that matter forward. With
Can I have a guarantee it will be considered at the next meeting, which will be my last meeting?
I can't see why not.
Well, we've got such a thin agenda tonight.
Yeah.
This has been part of the problem the entire year. We are not considering enough issues.
So,
and we
okay,
should
Councillor
have done
Atkinson,
a substantial
thank you very
piece
much.
of work about the hospice.
Okay, thank you. Points making being made, and please do write to me as well. You are welcome if you have any other concerns.
I did write to you about the hospice previously, and you were reluctant to discuss it at the last council meeting,
Yeah, because
committee meeting.
Okay, this is no point of debate here, Councillor Atkinson, at the moment, but we are considering.
So
it
do
as
I have
part
your
of the work
commitment that we
program.
will discuss it at the next committee meeting?
I will come back to you on that. I cannot commit now.
Should it not be for the committee rather than the chair alone to decide on the agenda? And I would certainly, we might not have all the answers, because I think the NHS consultation...
Can you put the... yeah.
I think the NHS consultation on the future of palliative care services will not have been finalised by then.
That's correct.
But I think because both Councillor Atkinson and I are leaving the council when we have an interest in this, it would be very helpful. So, I mean, if it's the committee's wish that we should have a discussion and a paper on the subject of the future of the hospice at St Charles, I think that should be the case.
Okay, thank you, Councillor Williams.
Thank you.
Taking that, I will talk to Jackie to see how we can organize this for our 3rd of March meeting.
Thank you,
Because
Chair.
of its importance. And
I'm
we'll
sorry,
discuss
I'm
it with
sorry
the
to
rest
keep
of the
going on
committee.
about this, but it shouldn't be for officers to decide whether or not or how much time we spend
We-
on an issue.
Councillor
This
Atkinson,
committee thinks this is an
please,
important issue.
Thank you, Councillor Atkinson. Yeah, it's okay. You are a member of this committee. You are tasked with the other matters. You had the opportunity to discuss, include certain things in the work program. And as Councillor Williams just stated, if it is a concern of the committee members to make some adjustment, modification to the work program, I can't see why not.
Thank you.
So, yeah, thank you. And I can see how strongly that's feeling it. So, yeah, we'll accommodate that. Thank you, Councillor Williams, as well, for that observation. So, based on that correction and the observation by committee members, the minutes will be corrected accordingly, and then I will sign them off based on that correction. Councillor Spalding, please. And Councillor Atkinson, can you turn your microphone off, please? Thank you. Councillor Spalding.
Thank you, Chairman. This is just two very small typos.
Okay.
I assume we're on the second set of minutes now, yes?
Okay.
We seem to have moved on to. On page 3 of those, the third bullet point down, the last sentence, I think it means to say to identify gaps and issues. Third bullet point down on page 3 of the second minutes.
Okay. For the Afghan...
And so that's a correction. And then also on the last page 6, in the paragraph that Councillor Atkinson referred to,
yeah.
Councillor Kamali, it starts off, it's the fourth line from the bottom. A supplementary planning document was put round the lad. Well, I'm not sure who the lad was or how you put a document round him, but I think it's a typo for something else, and I'm not sure what it was.
Land, L-A-N-D.
The land.
Yeah.
Oh,
It's
well done,
typo.
Chairman.
Yeah.
Thank you.
Thank you very much. It's done? Councillor Spalding? Okay, right. Okay, any more from the committee, please? Yeah? No? All right, thank you. Okay, thank you very much. So these will be corrected as from the last observation on the minutes, and we'll make sure that when they are circulated, they will be far more accurate than this. So thank you. Now we'll move to item 4, and we have tonight a guest speaker. So we are starting with the report from the Health Watch, Central West London, on accessing healthcare digitally. I would like to welcome colleagues from NWL CCG to this meeting to discuss the report. Can I ask Olivia Clymer, please, Chief Executive of Health Watch, to introduce the report.
Thank you, Councillor. We're delighted to bring the report to you this evening. We'll look forward to your questions. I'm going to hand over to my colleagues who actually did the work to run through a short presentation we've got that will help bring questions out, I hope. Thank you. Go, Shukri.
Hello everyone, my name is Shukri Halaner and I'm the Research and Project Officer at Health Watch. So with the start of the pandemic, it became very clear that the way of accessing healthcare services will become very different, especially with digital being mainly the only way of accessing healthcare services. So we sought to understand how this change has affected people and how... Can you hear me back now? Okay. Thank you. So we sought to understand how that change has affected people and how they now engage with healthcare services given the light of the pandemic and the use of digital technologies. So next slide, please. Okay. Thank you. So throughout the conversations that we've had with local people in Kensington and Chelsea, numerous themes came up, but throughout every single conversation, these 3 points were the most prominent. So one person told us that digital tools must not replace other modes of accessing healthcare services. A lot of people were worried that with the increase of online consultations such as Dr. IQ or eConsult, that is the only way that they can speak to GP practices. However, with the easing of restrictions throughout the year, some people, when they were to call their GP practice, they were told that they have to use eConsult or any other type of platform, which in that period was not the case. Maybe you won't be able to see it clearly, but one person told us that it's a bit odd because you don't get the nuances. I'd rather see a doctor in person. So for some people, whether they can access healthcare services online isn't always the main factor. Some people like the reassurance of being in the physical presence of their clinician. Another point that came up in all conversations was for there to be improved visibility and accessibility of translation services. And this is both online and offline. In one conversation that we had, one person said that before today, I didn't know about the translation services that are in offer, and that was for both online and in-person services, and GP consultations. And then the third theme that came up was concerns about privacy and security. So there are a lot of people that are very hesitant or very reticent to using these different platforms, and privacy was a key point to that. I think there was one meeting that we had where we had staff from NHS Digital, and they were able to directly ask the question of, where does our data go to, who stores it, and how long is it there for? And when the person was able to get the answer to that question, they were much more at ease, so more likely to use these platforms. Next slide, please. So throughout these conversations that we had last year, of course we spoke about the technicalities of using Zoom, on using GP websites and eConsult, Dr. IQ. However, a lot of the conversations about digital were reflections on healthcare services in general. So people wanted to know what services are accessible to them, what's out there. People wanted to know about their rights and for their choices to be respected. And there was a conversation about information, particularly about public health information. So where do people go to get these this informational material? Okay, next slide, please. So before we go on to recommendations, one point that I would like to raise is that is about the kind of COVID methodology. So when we, of course, with the height of COVID, there was a lot of pressure on a lot of energy on kind of explaining what the coronavirus was, how you can prevent it, what the vaccine is and what it does, and how long, the effects of it is. However, one conversation with a member of the local community, they told us that the only information that we can get is about vaccines. We would like the same method of kind of getting GP clinicians, researchers, scientists, public health staff members to come to the community and speak about prevalent diseases like diabetes, high blood pressure. And I will pass on to my colleague Adetta to talk about the recommendations.
Thank you. So what we've learned during this work is that many people have liked and embraced accessing health digitally, and it worked best when patients had a choice when to access healthcare digitally and when not. And also when they had established relationship between patient and healthcare professional, and also when it was used to manage already diagnosed long-term medical conditions. Digital health access, triage and consultation platforms were introduced very quickly and fast, and there was not enough time for patients to adjust in accessing services, in the new ways. And therefore, NHS will have to take time to engage with patients and to allow patients to catch up, with the new ways of receiving and accessing health care. And we also have to accept that there will always be people who will not be able to or just wouldn't want to access help in this way. And one more thing, I think we mustn't forget that NHS is free at the point of access, and digital access is actually not free. There are costs attached in terms of, getting gadgets, broadband, and other costs attached, and phone data can be very expensive. And things like digital poverty, it is actually a real thing. So therefore, we really have to be aware of those things when we talk about accessing health this way. So now talking about recommendations, it's probably very hard to see what's there, but I'll go through them. So the first one is commitment to respect patient choice. So the choice was really clear, during the work that we were doing, and it was mentioned that people liked, being able to access services differently, but the choice was, having a choice was very, very important. So the recommendation is that people should be given a choice on the mode of communication and the type of appointments they can have. And if it's not possible, then it should be explained why they can only have online or on the phone appointment. During the height of the COVID pandemic, it was acceptable that the clinician will make a decision on the type of appointment based on the clinical needs. But this report shows that there are many other reasons why a patient would need to have an in-person interaction with a health professional. Now that COVID restrictions are lifted, patient needs should be acknowledged and their choice should be respected. And GP practices should have their doors open so that people can walk in and speak to reception staff. And GP practices should let patients know that this option is available to them. So that's the first recommendation. So recommendation 2 and 3, we kind of merge them together because they're very similar. Well, not similar, but they kind of complement each other. Raise awareness about services available in the community and how people can access them. So many people that we spoke to no longer knew how to access NHS services, and moreover, they didn't know what services there were available for them in the community. Over the last years, many changes took place in healthcare, like new healthcare roles were introduced, like link workers, clinical pharmacists, community physios, and there are also services that people can self-refer. And so we found out in our conversations that there was very little knowledge about those services. So we recommend that information about healthcare services and how to access it needs to be produced in all formats, and that includes translating in different languages and also promoting, using different platforms and means. The routes and choices of access to healthcare services need to be clear, and our GP practice audits and mystery shopping that we did with GP practice telephone lines show that a lot of them samples people to online platforms and don't really offer other options of access. Local NHS and public health need to raise awareness of people's rights to NHS services, and patients' responsibilities also need to be explained. Recommendation 4, health information materials to be created and designed with local people. So health and public health must tackle this issue as a priority. Information that is created should address what patients and residents want to know, and not only what NHS wants to tell them. It needs to be a two-way collaboration. Local communities and Health Watch Centre West London's members should be included in creating health information materials, and NHS and public health need to address issues of availability and visibility of this information, and specifically translation and interpreting services shouldn't be rationed. Instead, it should be promoted in a practical way, and it should be a patient choice whether to use interpreting services or not. But the starting point, they need to know that these services are available to them. Recommendation 5, a regular review process of public material, regular review process of public material with local people and Health West Central West London. So NHS is changing very, very fast, and information needs to be reviewed and updated regularly to make sure that it's accurate, and it needs to be promoted using all available platforms and formats. And the last one, recommendation 6, accessibility audit of all online services. One of the benefits of using online platform is the ability of having additional access tools, such as translation into, options and voice activations options. There are all kind of accessibility tools available, and this needs to be activated and promoted and used. I think I'll stop here, and I'll pass on to Olivia now, and we'll talk about next steps.
Thank you. So we've been really delighted by the support and response we've had to this. We've had an excellent meeting with Anna as Director of Public Health for the Borough. We had a really practical session with colleagues about how we were going to do this, how we were pulling out the challenge of that nuanced messaging, that gap between wonderful services that are provided and yet people not knowing about them and having confidence to access them. So that's been really encouraging and very exciting. We're delighted to say that our local committee members and members of Healthwatch and local patient participation groups have checked, and the doors of our GP surgeries in these boroughs are open, which is excellent to hear, and thank you so much. And that's a great message we'll be able to share back. But they've had the feet on the ground and the doors are open, which is really encouraging. We'll continue to work with our NHS colleagues, and I'd flag up Rory's EPIC programme and the intention of NHS colleagues to work more with local people and residents, not only just for the one message when they need it, but to keep that conversation going, to build those relationships. And we hope to continue and support to do that with our local practices, their patient participation groups and PCNs as a key part of our work. So we're very happy to take questions if you're interested, and would welcome those. Thank you.
Thank you very much. It's quite interesting and exciting time, especially now what the NHS is going through, and I'm happy to hear that the level of participation and involvement within our council, the local community, and what you are trying to do here, Olivia, in your team is greatly appreciated. And on the issue of digital and digital transformation, I'm sure from your stakeholders it will be appropriate to have the NHS digital team next time with us to answer on the preliminary work, excellent work you've done in the field during this pandemic time. And this is really greatly appreciated. And there are out there, I can assure you, colleagues who I know and I worked with a long time on digital transformation. They are happy to assist. And I know many universities who can participate in this field. And digital is the way forward. However, I know from, for example, one country I'm aware of, Australia, one example, when they've done their digital transformation, that's more than 20 years ago, it's embedded within their legal system that access and giving that choice is a right. So although I'm pro, and we are moving, as you've seen during this pandemic, we are using digital. However, this should not take away the human right. That's if they are favorable or particular access, especially to services, medical services, that's critical. So I thank you for that effort, and I'm sure there are other institutions out there when you expand more that will receive quite well this approach. So thank you so much for coming and presenting here to the committee. Now I will take questions from members of the committee, followed by councillors attending the session here. So I turn to my committee members. Councillor Addenbrook, please. Switch on. Then Councillor Williams.
Thank you, Chair. And I think one of the things that obviously stands out is we're talking about digital, but there are people digitally excluded, and we must not forget them. I just wonder if you could elaborate a bit on the groups that you engaged with. You mentioned Midday and some national charities and One New Westminster. And further on you talk about Age UK, but did you engage with people like Action Disability Kensington and Chelsea, Full of Life, Carers Network, the Kensington and Chelsea Over 50s Forum, Community Champions, COVID Champions? I'd be really interested to know who you did engage with, because obviously different people engage with health services in different ways. And I think, whilst this is a really good report, I think it needs a bit more detail. Thank you.
So when we're designing this project, we looked at specific groups that we wanted to reach, so people with sensory impairments, people with disabilities, various ethnic backgrounds, ages. We also involved young people as well as older people. So we kind of had a very clear list who we want to talk to. Of course, we knew we couldn't talk to everyone. But we have, so in terms of Age UK, there was a very specific group who, how are they called? Sensory
So there were a group from Age UK that were also linked with the Macular Society.
Exactly.
Macular degeneration.
Yes. So people with the visual impairments. We also had another piece of work with people with disabilities who also told us, you know, how difficult or easy it was for them to access services. So we didn't aim to communicate and to listen to every single group that there is in the community, but we wanted to reach people that were identified that we wanted to hear from, and that included disabilities and impairments.
Councillor, we can circulate a note of the groups that we did participate with, and this report now is in the public domain, so it will become part of a conversation, an ongoing conversation, because it's been a significant piece of work, so we want to make the absolute most of that effort, and that will be you know, getting challenge and comments from others and other sectors of, you know, nuanced groups in the communities. So thank you.
On that note, Olivia, sorry, do you have any more to follow up? On that note, are you going to tell us about the methodology being deployed?
Yes, so the way that we kind of engage with the different community members. So some people were within our network already that we could seek to see if they knew other people who maybe we haven't previously worked with or haven't worked with other organisations. So the way that we did it, we spoke with the community leader, if it was a community group, or the chairperson, depending on who it is and depending on the group, to see if this is something that their members or their group members would like to take part of. Of course, with COVID, a lot of people wanted to get in contact with a lot of different organisations, so they were very stretched. A lot of people, some of the community groups don't have a lot of people or time to spare to kind of do different groups. So those are the types. So once we spoke with the chairperson to kind of understand the initial views and opinions, and if they were open to having this discussion with us, we could set a time that's most available for them, whether it's in the morning or the evening, to have that conversation with them. And with some groups, after the conversations that we did have, if they had any requests, I know that there was one group that worked with refugees and migrant communities, and they asked us to create a presentation or some information about access to different services and through translation services, so we were able to do that as well.
Thank you very much. Yeah.
And on page 6 of the report, there's a note on methodology and approach. Because we've worked in the community for quite a long time, we've got quite a lot of networks, and our small grants programme has provided added connections, but I'll circulate a note so you've got exact record. Thank you.
Thank you, Olivia, for that clarification. But yeah, that notes will be helpful to accompany your good report there. Councillor Williams, please.
Thank you, Chairman. I mean, would it be unfair to say that the people you interviewed were not wholly representative of the population of the borough as a whole, and that perhaps there were groups who might, perhaps those who might find digitally challenging which fair enough were over-representative, because I mean my concern is we've got relatively I think mobile young population, particularly in the south of the borough, and many of those will find the digital offer very attractive, and I think it's important that they have that option, not least because it's they are the people where, in particular, where early diagnosis of particularly cancers can save a life. And there is a service called GP at Hand, which is operated by Babylon Healthcare. I don't use it myself, but it is it's very much online first. I think it's very popular, and if you have to see a GP, you have to go to either Fulham or South Vincent Square. There's no centre in the borough. Now, of course, if our practices don't adapt to the new normal, I think that service, and perhaps others like it, will suck patients away, and that might actually affect the viability of some practices. So, I mean, I hope that our practices will adopt the digital model, digital first model, with enthusiasm. That said, of what I have seen, the apps have limited utility. But as I say, I think we need to be very positive about the digital ways of engaging with the health service.
Thank you, Councillor. That's a very appropriate and helpful challenge. The focus of the report was trying to draw out where there were challenges and to illuminate that, and to illuminate the layers of that challenge, really. I think your point around that wider community is very helpful. There are lots of people who have preferred and do use digital. We have a report we produced in 2019 regarding young people's experience of digital, and whilst yes it is welcome, there were issues around the trust of the channel, what happens to their data, and continuity of care, and in terms of who they see. So I think there are lots of positives, and we definitely hear that in our wider work, but with this we were particularly looking at some of those challenges. I think what we can add to the report is a paragraph around that and the wider uses, which perhaps other data we can pick up from NHS colleagues, for example, so we can give some context on the borough as a whole, if that was helpful. Thank you.
Thank you. That's,
yes, I'd also like to add a, sorry.
Yes.
I'd also like to add a point about young people, and we did speak with a couple of young people from our Young Health Watch Westminster branch of Health Watch Central West London, and from speaking to them and speaking to colleagues, there was like an assumption that young people would like to receive information from social media or use technology to access digital services completely, but that wasn't the case. Whilst they would like to access information and have that information in a centralized place, which they couldn't find, that sometimes they do like to go in person to speak to their doctor, sometimes more broadly, so young people and older people as well, use kind of gateway excuses to see their GP, which sometimes they may not be able to do so on an app, for example.
Okay, thank you very much. I call now to Councillor Spalding, then Councillor Woodger, then Councillor Atkinson.
Thank you, Chairman. Thank you for this report, but I'm afraid I'm going to question some of the reliability of it. Of the bar charts that you show, the first one has a sample size of 29. The second one is 25, the third one is 25, the last 20, and then 18. I'm not sure if these samples overlap or if they are separate samples. If they're all separate, that's only 117 people, and I'm not sure how you chose them, whether it was randomised or what was the basis, as the chairman said, the methodology. So would like to just investigate the sample size, the randomness, and the reliability of the figures. That's the first question. The second question is, in your report, you talk about face-to-face appointments. Now, I'm not sure how face-to-face is defined, whether it's actually a real person-to-person consultation in a surgery. And you say that 60% of consultations were face-to-face. In the minutes of the last meeting we had, I think you refer to a figure in March 2021 as 60%. In our last minutes, Dr. Steeden, he sort of defined face-to-face as virtual and face-to-face. And this was in September 21. And in there, he said the figure was 53%. Well, that seems to me, between March 21 at 60% in your figures, and in September 21 in the NHS Dr. Steeden's figures, we're down to 53%. And he even allows face-to-face to be including telephone. So it seems it's falling. I just wonder if that was one of your findings as well. Thank you.
So if I first come back on methodology, so this is a qualitative research piece of work. So this was workshops and people having the space to have those conversations, and we're pulling out the themes from that. This is not a quantitative survey or hard copy survey. Giving people quantitative will give you the answers to questions. The qualitative work helps the conversation as to why. And I think in this instance, with the use of digital and what that means and the experiences of people, this is what we're trying to draw out with the report. So we're very clear with the reporting on numbers, because it's not about the numbers, and we don't have the capacity for the numbers. And I would reference the RBKC survey, resident survey from last year, which only had 600 and odd responses. I know you're working hard and we're supporting to increase that, but that is a quantitative exercise. This is qualitative, to give people the space to be listened to and have the conversation around that, and then we draw out the themes from it. In regard to face-to-face, I mean, I think our, Detta will jump in and correct me, but our understanding is a tangible face-to-face. That's what we in the pub, lay people understand. It's going in there and seeing somebody across a desk, so to speak. And it certainly has improved over the year. We would from when we started doing this piece of work, and the feedback from patient participation groups and local members of Healthwatch across our boroughs is that GP doors are open, and that's from last week. So that's really encouraging. But I think, I can't comment on what the NHS figures are telling us. This is just what we were able to capture through this work, Councillor, but welcome the challenge always.
Thank you.
Okay.
Thank you for that clarification. I'll call Councillor Woodgate, please.
Thank you, Chair. Do you think GP usage has lessened or increased, do you think GP usage has been lessened or increased by digital services? Or would you say it's hard to measure because the pandemic has meant a lot of people have sat on their feet in terms of not going into GPs, obviously, while the panic's been happening. The other thing I'm wondering about is usage of digital versus in terms of having a better quality appointment. I went to and had a hygienist appointment the other day for the first time in a very long time, and I had to fill out an online survey of my background, which was quite helpful. So it meant the appointment was more like we just got on with it, as opposed to them quizzing me beforehand. I thought your comments.
So this is what, what we think, what we hear, and, that's, from what people are telling us, and also what from GP practice are saying. So GP practice saying that there are much more, they managed to see and to look after many more people and to see, to have more appointments. So in terms of numbers, we were told that they managed to offer more appointments to patients because they have these digital tools now. I think it's really difficult, for us to say because we don't really see the figures. But it became easier for some people. So we're talking about digital health. So there are new ways of accessing services. It used to be, walking to GP practices. Now we have telephone in addition to that, and digital access. So for some people it became easier to access because of digital. So filling in the form, on the weekend or after hours, it's convenient to some people, and therefore it seems like more people are using this option now. But those who are not able to use this option find harder to access help.
I was just going to add, there's that understanding of what the digital offer is. I mean, we've picked it up with an earlier question. Is it a digital triage, or is it sort of a screen consultation? So there's work to do on communicating what is meant by our digital offer now. And we've been able to participate in, we've run workshops to support the specification for the new e-consult modules in North West London on the back of this work. So the residents in our boroughs have been able to participate in helping to shape what's good and what they would like to see in those e-consult modules that our GP practices can choose to commission. But it is work in progress, I would say, in this area. Thank you.
Yeah, thank you very much. Okay, Councillor Atkinson, please.
Thank you, Chair. Actually, I'd like to thank you for the report, and particularly for your conclusions. Though I must say, I like the conclusions, but I would like you to strengthen the evidence of them, because I think what the conclusions you've come to are very important. It is a question of horses for courses, and I think, as I've said in this committee before, young people, young busy people, seem to have no problem whatsoever with accessing information, making appointments, and even doing consultations. But older people are very reluctant to do it, and I do think my own experience, and we all talk to an extent of our own experience, the COVID forced me into doing telephone conversations and then later online conversations with my GP. Worked out fantastically. I wouldn't have done it unless I'd been forced into it. But, some of the conclusions you come to are, I think, very significant. There is concern about cost for people who are not well off. There's a massive concern about trust, which I think we should all listen to very carefully. And the fact is, people trust the NHS, they don't trust the other providers, and I think that says something important. And apart from face-to-face, and I'm really glad you emphasise the fact that people prefer, particularly older people, prefer face-to-face. Their second most important, their preference is telephone conversations. And to widen it out a bit, what I fear is what has happened in other fields, that the banks first of all went away from face-to-face conversations and then moved on to telephones. Now I like telephone banking. The banks have now made it extremely difficult to deal with people over the phone, and they're constantly pushing you into doing stuff online, and I think the health, it's exactly the same. There's a danger that health is going to be exactly the same. Now, I mean, I would say your findings on translations, whilst interesting, I don't think are central to the point that I would wish you to continue to emphasise, and maybe deal with that issue separately. But I think what worries me is that there is a percentage of the population, the oldest, the poorest, and those sectors are those with the worst health. It's what we mustn't get away is being carried away by young, busy people in work who understand the online systems well themselves, or more affluent middle-aged people who have got their children to help them. I mean, that all helps. But nevertheless, I think the idea of the NHS is that people should be able to, I mean, far be it from me to quote Tory health ministers, but that's what they've been saying, that the right to a face-to-face appointment is not just something that has to exist on paper. We need to make sure that we back that up, and that the health service doesn't go the same way as the banks or the or even supermarkets. It's all the same, and they constantly claim that they are being led by what the public wants. And from my own experience in all those areas, it's not true. They can continue to tell us over and over again that you want this. I would want to see the evidence. As I say, I commend your really strong conclusions at the beginning, but I want you to keep working away at it. And I think we as a committee and we as a council must not forget that there is a significant part of our population that isn't online because they're either elderly or they're poor, and we mustn't allow the simplicity or the ease with which some of us can access it. We mustn't forget those that can't. Thank you, Chair.
Thank you, Councillor Atkinson, for your extensive elaboration there, which is acknowledging, as you can see, that's it's a good work, but we don't need to forget these marginalized, sometime forgotten, we should not forget. So thank you. Yes, you want to come on this?
Sorry, I was just going to say, Councillor, we brought it to Westminster, and we have a slot, I think, in 9 months to bring the report back, or to bring sort of an update back. If councillors would welcome that, again, we'd be happy to do that. Thank you.
Thank you very much. No, this is quite good and excellent exercise to share with us, and we appreciate all the efforts you are doing there to bridge the gap between our residents and the NHS and what they are offering, because the new strategy is digital first. So, but we need to understand what that digital first is. And since it involves medical and highly emotional in most cases, addressing the physical as well as the mental health and other criteria for treatment, we have, without further to say, Dr. Stephen here, who is the Borough Medical Director, West London NWL CCG. So I welcome you if you want to provide any observation on the report before I call other councillors in the chamber to further comments, please.
Thanks very much for the opportunity. It's a great report and incredibly helpful. And I know Rory and the comms team from North West London will be working with Healthwatch to take forward the recommendations. I mean, I just want to reassure the councillors and Healthwatch and the residents that the speed with which we had to go towards digital first was forced upon us by the constraints that COVID brought, and an attempt to try and keep primary healthcare services open during the COVID pandemic. None of us want to see e-consults or digital replace anything that we traditionally have been able to offer the residents in Kensington and Chelsea. It really is about adding to the offer and not replacing anything at all. If I can answer some of the particular questions around that were raised during the committee's questions. We do have records about increased activity in primary care, which we'd be very happy to share with you. I don't have the most up-to-date ones, but the ones that I can recall reading last were reporting a 30% increase in GP contacts. But the exact period of that I don't have, but we can get that for you. And the e-consult, which is the model that GPs currently use for some written online consultations, is currently up for review. And there will be a process whereby we are going through a procurement of another type of online consultation offer, but during that consultation process or that procurement process, there is a great deal of evidence shared around patient engagement in the design of the e-consult method and patient satisfaction reports as well. So maybe once that procurement process is over, but at a North West London level, we can bring that back to you with some of the patient data too, and reassure eHealthWatch with that too.
And I'd just like to support that, because we've run workshops around that specification and what works and what doesn't, or what people need or what they would value, both those who are very digital savvy and wider community members, to support that, so wider engagement, which I think has been, it's quite brave of North West London, and they took the challenge, so it's much to be encouraged. Thank you.
Yeah, thank you very much. Any member of Dr. Stevens' team want to add any comments? No? Okay. Thank you, Dr. Stevens, for this observation. Based on that, I go back to the committee, since we have that additional comments. Anyone wants? Yes, Councillor Spalding, please.
Thank you, Chairman. Some of the casework I get from elderly, isolated people, we have to remember 40% of the households in this borough are single households over pension age. And it's a demographic that's growing because of the baby boomer generation after the war. And I know there's a shortage of care workers, but I wonder if, I found with some of my casework on housing, that it's the care workers who are younger and more digitally skilled who have contacted me on behalf of the person who's being cared for. And I wonder if we are doing any work on making sure that home care workers can act as digital advocates for the elderly, isolated people that they visit. And if we're not doing any work on that, should we be? And should it be part of their training? And would it enhance the professionalism of the care workers if they were shown how to use digital access to primary care on behalf of the people they're caring for? And I don't know whose responsibility that is, whether it's public health or the NHS or the Borough Social Services.
Can I have Gareth, please? Go ahead.
Thanks. Happy to take that. We've got an item about home care later on the agenda, but in relation to those capabilities for home care workers, those who work for agencies will receive that training from the organisation as part of their skills for care qualifications as home care workers. For those home care workers who may be personal assistants working with people who have a direct payment, that's part of our responsibility around making sure that those personal assistants, if they're not allied to an agency, get up-to-date information about how to report changes in somebody's care situation to appropriate health colleagues, or internally if there are safeguarding issues that need to be raised, etc. Some of that, and we'll come on to this perhaps in the next item, may be assisted through some of the digital proposals that we might be making as part of the recommissioning, but there are currently mechanisms in place for home care workers to do that either through their agencies or to us directly.
Yeah, thank you, Gareth, for that clarification. We'll explore it further in the next item. Yeah, thank you. Any member of the committee? No, no more. Can I call upon councillors who are present at the moment if they want to have any questions? No?
Can I
Yes,
make a
Councillor
comment?
Rossi.
Following on from what Malcolm Spalding was saying, I think that a lot of our elderly people do live on their own, and I think their relationship with their doctor might be, or probably is very important to their mental well-being. And so that's another reason why they'd want to go in, or they'd want the doctor to come to them, just to maintain that.
Okay, thank you very much. So at this point, we'll conclude this item. May I thank Olivia and her team, Health Watch, for bringing this report to us and discussing it. And we can see the level of challenges facing us, even in the public sector here, working closely with the NHS, and this closely appreciated bringing any challenges to rectify the situation and lessen the impact, especially on the elderly member of the population or the less able to access digitally the platform of services. So that's greatly appreciated, and thanks to colleagues for your extensive questioning there. So I'm really grateful that this issue will be continuing and the further collaboration assuring that extra work needed to be done has been highlighted here. So I'm really grateful for your report, and thank you, Dr. Stephen, and your team for the responses there and the further clarification on that issue. Thank you. Now, I conclude this item here, and we go to item 5. And this is to do with the recommissioning of home care services and market management. Now, we have the report which been with the outline ongoing recommendation of home care. I would like to welcome the lead member, Councillor Kamali, and Gareth Wall, Director of Integrated Commissioning, for the meeting to introduce the report. Councillor Kamali.
Thank you, Chair. I've sort of wondered at home how best to present this paper. Much of it is obviously rather technical, officer-led, procurement policy, and sort of making sure that we're delivering a safe and good service to our residents. I suppose really for me the important things are sort of touching upon what was mentioned earlier around the digital first. Obviously we're sort of recommending that we improve the number of people that are using direct payments and managing their own money themselves. There's obviously a national issue with care and the workforce. We're obviously putting on a care fair at the end of the month into early March to try and tackle some of the issues around the training that goes with becoming a carer, but also sort of perhaps making care much more of a career rather than simply a job, as so many of the carers do believe it's a career, and it absolutely is. We need to make sure that we're hiring and retaining people which are able to work for a number of years to really understand the borough and the service that they're offering. Obviously COVID has had a huge impact on all of this. The way that we've had residents living at home, making sure that they're well looked after, checking up on them is something that I think we can take away some good learning from, but perhaps we need to make sure that there are better sort of ways to engage with residents which are receiving our service, and perhaps sort of improve on the way that they can report in, as Gareth touched upon earlier. The actual procurement itself, as the paper says, is sort of on track, and I'm sure Gareth will be able to elaborate more on the actual technical assessments that will be going into it. I think for me this sort of reiterates an issue around the population that I believe Councillor Spalding mentioned. We do have an ageing population in Kensington and in London and in the country. This is not a secret, but it does mean we have to plan for it. We have to plan for a diminishing number of people looking after an increasing number of people in a very competitive employment environment at the moment. I've come away from meetings with Gareth where I genuinely wonder how we will hang on to carers when they can earn 50% more behind the till at pret-a-manger around the corner. So it is clearly, it's a calling for a number of people, but we have to make it reasonable in career prospect as well as sort of employment, but also there's then the income issue and the cost to the council in trying to compete, which we unfortunately will be doing. It's not going to be a surprise to anyone that inflation is absolutely something we're talking about an awful lot. I'm sure this will be something that Gareth will be tackling as he goes out to procure. But I'm very determined that actually people do want to continue working in Kensington and Chelsea. We were discussing with Viz ways that we can make working in KNC that much more beneficial to the person, be it in partnership with museums or offering some form of ability to get around the borough, those sorts of things. Not least also the key worker housing pilot as well, that we've sort of rightly focused on NHS, but in fact care is very much something that should be included in our key worker policy as well. So I'm afraid I don't have more details on where the contract itself is heading, and I defer to Gareth on that one, but really those are my thoughts on obviously why we need it, and I think some of the challenges that will be presented to us. Thank you.
Thank you, Councillor Kamali. Gareth, do you want to elaborate on any of the points being raised in the report?
Thank you, Chair. Yeah, just a few points I think it's just worth pointing out from the report. I appreciate you've all had it. One is just a bit on numbers. We talk about 640 residents currently in receipt of home care, but as Councillor Kamali says, that number is likely to increase in age and also in complexity. This is one of the things we see across the piece, not just in home care, but is in happily people living longer, but more people living longer with more complex needs. And that presents a challenge to home care as we see more cases where people require more specialist care, where people might require 2 people to care for them at one time. Some of those things are complicated to arrange and costly for the taxpayer. Currently that's costing the borough somewhere in the region of £7.65 million a year. Looking at the modelling, we can anticipate annual increases of that figure pushing towards £1.5 million a year. So that's why we're looking at some of the different models in the recommissioning exercise, whilst holding on to what we know works. The report also sets out some information about the performance of current provision, as well as looking ahead to future procurement. We currently have a model which is common in a lot of places, particularly in London, where we have what we call patch providers. So home care providers that are contracted on a geographical basis, clustered around numbers of need that we know in kind of broad geographical area, and where that makes sense to draw lines. Of those, one is currently under CQC's requires improvement, so it's effectively tier 3 out of their 4-stage grading of outstanding, good, requires improvement and inadequate. That's a technicality from our point of view. We're not complacent, but the registration of that home care provider is actually in Hammersmith and Fulham, and it's the requires improvement element applies mostly to the Hammersmith and Fulham provision. Our contract officers and commissioners have been working as part of the improvement process for that registered provision, and as part of that we are requiring them to disaggregate so that there's a specific RBKC one. We are content through quality assurance work that provision remains good locally, but we want to see the full outcome of that improvement plan. Our other providers in the patches are good and have been supported by our officers throughout the last 2 years, both directly in terms of their practice, but also in distributing the various rounds of emergency funding for infection prevention control and workforce recruitment and retention. In addition to those patch providers, we have 12 spot providers. All of those, since the last uplifts, are required to pay London Living Wage, and the vast majority of those are also CQC rated good. There's a section of this report that refers to the vaccination status of home care workers. At the time of writing this report, we were working very intensely with the sector to make sure that as many people as possible had received the requisite amount of vaccinations by the 3rd of February in order to meet what would then have been the deadline for mandation across health and social care of vaccination. That position has changed since this report was published. However, as I've said before, the letter and the law of the spirit of law are two different things, and we continue to work with all of our agencies and partners to try and encourage uptake of the vaccine amongst staff, regardless of whether that's mandated or not. It may be slightly helpful in the fact that fewer people will leave the service. We are close to 80% now of home care staff who are fully vaccinated, which is a really good position in comparison to other places. So despite the change in the national position on that, we, like other places, are continuing to drive it forward. And then just briefly, if I could, on the new approaches. The paper sets out what some of the challenges are for home care. So in addition to what's been said about recruitment and the population change, COVID has clearly had an effect on that as well, and has been supported somewhat by the rounds of investment that we've been able to distribute. But we have seen some fall away, as have other parts of the country, in terms of people coming forward for home care work. Hence, things like the Care Fair that Councillor Kamali has mentioned, and a programme of work that will happen throughout this year that we're working with Comms on to try and attract more people locally into the home care workforce. Part of that relates to some of the proposals around recommissioning home care services. So there's a logic to sticking with a degree of the patch model that we have at the moment. It's well known by some of the larger agencies. It provides a degree of stability. It works in terms of managing costs. So you have a patch so that you're managing travel costs and time for somebody getting between one property and another. What it doesn't help with necessarily at the moment is that model tends to be dominated by large organisations, some of them London-wide, some of them national. And we know that with the degree of fragility that there is in the social care market, that presents a risk. And we've seen that in previous years where some major home care providers have either been bought out or have had to withdraw from the market, and very rapidly social workers and others across London boroughs have had to reassess people and find other providers for them. And that sort of disturbance is not ideal for residents, but also a lot of work for the staff involved as well. So one of the proposals here is to maintain a patch model, but to diversify the pool of supply as much as we can. And that's by trying to do some of our market development work, which is our responsibility under the Care Act, to encourage organisations to develop themselves, to come forward who we might support to develop, who perhaps don't provide home care at the moment, but maybe could, where there are particular needs of or interests of a specific community in different parts of the borough. And we think that there's strong potential for us to do that. So diversification, but maintaining a patch type provision, and within that proposing something like a core and flex model. So at the moment our contracts on patches are entirely activity based. We don't guarantee hours to home care providers, but there's a broad understanding of what those hours are likely to be. One of the challenges for staff is around 0 hours contracts, which are very common amongst home care provision. A lot of staff like that because they like the flexibility and request it. But actually, there are commonly understood challenges with 0 hour contracts across different types of industry. So one of the things that we've been talking to some providers about is offering a mix where for a degree of staff, particularly where you've got challenging need with things like double up care, so 2 carers or more sometimes needing to be present, or a number of visits during a day, providing a block amount for that, so that some staff might be able to be offered guaranteed hours where they're interested in it, and then offering flex above that with both the patch providers and beyond them spot providers. And we will always need some degree of spot provision in order to give ourselves some capacity. So modifications to what works currently. And then in addition to that, are discussions that we've been having with different organisations, but also with lots of residents and their families and family carers about different things that they are interested to try. And this is really in response to partly what is available and wanting to explore that, but also what people are telling us they would like to try. And some of that is around the digital platforms, and there are two in particular that we are exploring. One is something that we've talked about before, which is the idea of offering people in receipt of a direct payment a mechanism to manage that themselves through a virtual wallet. So this is effectively an online account that could be tallied or aligned to the MyRBKC account if somebody has one, so that they can manage their funds, see how they are being spent, what they're not spending and might come back to the local authority, or what they might use differently depending on how they're managing it, like manage your own bank account. And we're due to go through a pilot of that to see how people use it, what we might need to change, etc. So we've got an organisation we're going to run that pilot with who are already doing that in a couple of other counties elsewhere. That's not happening in London at the moment. But where people want to do that, and primarily with people on a direct payment. The second is a matching technology. Again, primarily this will be for people who are on a direct payment. It's an organisation called Currum Care that we've been talking to work with on this, which offers a matching technology, a bit like the underlying technology that informs dating apps. So somebody has a profile of need, and somebody has a profile of what they are experiencing and offering as a carer. It's odd to think of that as dating app, but I just mean that just purely in terms of the underlying technology. And that has to be a managed process, obviously, because you wouldn't want people making inappropriate choices or requests about who might be their carer. But it does allow people to express their preferences and for people to express their skills. Again, that is being used in other places in London and around the country at the moment, and indeed could well be being used here. It's a private organisation and people could just be using it. But in response to some of the interest from service users, as we've been going through this work, we've started to put forward some ideas about how some of these digital tools could help in terms of personalisation, efficiency, and helping us to potentially build that market of personal assistance. There's a bit of a brief timeline summarising at the end of the paper where we want to get to in terms of the contracts for the main home care providers by 2023, and we're reasonably confident of being able to meet that. But I'll stop there in terms of the introduction and happy to take questions.
Right. Thank you very much for this added value to your report. And I've made a few comments here. So if I start to thank you, first of all, on this brief, especially I was interested in the future vision. And the lead member nicely highlighted the starting point here about sustainability in the care system. So it's a good start to make it as a profession. So when you have a care cohort, so we can sustain that cohort for the best of our residents, so in order to ensure a better quality of life. And I welcome that strategic development there. Cutting costs, but it should not be at the cost of quality provision. Now you are revisiting all the contracts. Now, there is a 26% highlighted that's over the next period up to 26% increase in terms of our elderly population within that. So I hope this will be catered for in your 5 years plan. And the other thing is just a matter of concern regarding the failure of some care provision. I would like to ask what kind of system do you have to ensure in terms of feedback? I don't want to say complaints, but feedback in terms of any issue raised and what their level of complexity in order to deal with it. And the other one is for this geographic approach in terms of localization. I can see you have 3 points mapping in terms of north and south, then one corner where there is expressing concern about that provision. What percentage do we have as a spread between the 640 home cares in terms of percentages, like, because when you are targeting a specific geographical area and now you want to involve residents and local community in that provision, what kind of approach you are having in place to ensure, other than just training or attracting for whatever salary or profession, what other measure do you have in place to attract the best so you can sustain them in that in the care system for the future?
Okay, I'll defer to Gareth on the sort of that slightly more technical bit, but I suppose going back to your first question around the sustainability side of it, something that we've been discussing is very much that there are already carers in the community, but they're unpaid at home with their family members, and perhaps there is an avenue into employment with the skills that they've learned looking after their family, that perhaps we could explore. Having people very local in the borough would be obviously very beneficial, both for their time, but even if they're only being able to offer a very limited number of hours, perhaps, something like the matching technology that Gareth is mentioning and other apps, which one I saw on Nextdoor the other day called Companions as well. You know, that might all be that somebody requires. It's just somebody nearby in their community, very much sort of a friendly face down the road as well. So I'm very keen that we do pursue this sort of ground-up approach of local employment. It's obviously beneficial not just for our own local economy, but also for all of the carers themselves. There's a huge amount of time spent commuting, travelling around London. It just makes sense to be employed locally, especially if it's in your own community. And Gareth, perhaps you can answer on the actual numbers per one of the 4 regions, perhaps.
Yeah, just picking up your middle question as well about the kind of process of complaints or how people raise issues, whether they're carers or if they've got issues about the carers. That's a multifaceted approach, really. We have a complaints process, so people can come to us directly. They would probably go to the care agency directly first. They may talk to their care manager in a social work team. We have a quality assurance approach that includes both our commissioners and our safeguarding team, who have oversight of all of the home care agencies and that work. We have contract managers who will talk to the home care agencies directly about their delivery, and there are quality KPIs as well as kind of data output KPIs in their current contracts. And we have an information sharing arrangement across our practitioner teams, both social workers, occupational therapists and others, commissioners, and talking to the Care Quality Commission on a regular basis. So we've got a good, and that arrangement is particularly useful where some of these larger home care providers work across a number of different boroughs, and we can gather intelligence about how things are working in other parts of London. So there are numerous routes that people can come through to complain to us, and we do receive complaints. Quite frequently they are about practical measures, about attendance. If somebody is late to an appointment or if there is a missed appointment, and sometimes they are the reverse, where the home care agency isn't able to attend an appointment because somebody won't let them in. So we're able to intervene at those points. The sort of thing that the Care Quality Commission picks up is largely through its, the rubric of its testing, and a lot of that is to do with the quality of care and also the quality of documentation and reporting. So we see a lot of things through, and you'll have seen this through CQC reports, that are about the accuracy of record keeping, particularly medicines records, where they are stored and their accessibility to district nurses, etc. There's a particular challenge on that thing in relation to the digitalisation of care records, and where we've got a number of different agencies making sure that the records that are updated daily by home care workers are accessible to colleagues in the NHS and colleagues in social care, unlike having a paper folder in someone's house that everybody can see is updated every day. The proportionate spread across the 4 patches, forgive me, Chair, I'm going to have to come back to you with a particular figure on each. What I can say is it's not 25% each, which I imagine you'll guess by the way that those geographical lines are drawn. And some of this, if I'm honest, is due to the legacy of the way some patches were drawn under previous tri-borough arrangements. And that's partly why we see that issue with, you'll see Sage Care in the southwest of the borough at the moment, which is the one that overlaps with Hammersmith and Fulham and has the challenge on requires improvement. So the other benefit that we'll have in going through recommissioning is making sure that we've got proportions drawn in a way that's absolutely right for us. Not that this isn't working, but it's a chance to revisit some of that.
There is always a lesson to be learned, especially when things start going wrong. So I will now take questions from members of the committee first, then we'll go to the councillors in the hall. Councillor Addenbrook, please.
Thank you, Gareth. I know this is a really, really important contract for our residents going forward, and I know you're doing lots of work on it. I just wanted to ask a bit about direct payments and PAs. I know in the past we've had a number of ladies that have come to us who would like to have had employed their daughter, for instance, as their PA, because for them it was more culturally appropriate. And we were told that that was not possible. I'm just thinking now that, you know, you're looking at changing the model, whether somehow that could change, and that might actually not just benefit that family, but also benefit other families.
We can look at that again, and we have been looking at it again. There's been some change in our advice around the employment of PAs, but mostly in relation to the employment status of the person being cared for, and the kind of the liability for them being an employer, and the risk that sits between them as an employer and us as the funding organisation, and making sure that both the council and they are safe in that. And we've had to slightly adjust some of the advice there. That's not to do with the appropriateness or otherwise of the personal assistant being a family member or somebody who is close. But I will make sure that we're looking at that again as part of this recommissioning process, that we can clarify that advice.
Thank you, Gareth. Follow up. Christine, then Councillor Atkinson.
Hi. You've already talked a little bit about complaints and how you deal with them and the quality monitoring processes, which are multiple. Through the pandemic, what has been the alteration or change? Has there been any change in the number of complaints coming forward? And also, in terms of staffing, what's the current situation on staffing? Are the providers adequately staffed, or is there a big shortage? Those are questions about the current situation. Then going forward, looking at the resubmission redesign, could you tell us a bit more about how you are engaging with the public on that, and what the response to date has been, and what your plans are going forward for gathering feedback from both relatives, carers, current users, and residents?
Thank you, Councillor. On the current arrangements, during the period of the pandemic, the number of complaints has remained relatively stable and may actually have reduced slightly, but that's probably largely to do with, during a period of the pandemic, we saw a reduction in the number of packages of care as people stayed with family or were nervous about a home care worker coming around to their house. And where some of those packages of support are to do with relatively day-to-day tasks, and people might have been getting help from mutual aid groups locally, rather than having someone come in the house, people chose to step away from that. So we saw a dip in the volume of home care activity during particularly the first wave and the second wave of the pandemic, which is now starting to come back, which meant that the number of complaints, if not the nature, reduced in line with that. So probably the number isn't a good indicator of changing quality at that point, but there's nothing really that's showed us that there's been a detriment in quality. Your question about staffing levels, that has been challenging, and it's partly it's been a bit to do with the vaccination drive, and that may have caused some people to look to other sectors. It's also well, there is another point around staffing. Forgive me. Losing some people out of the sector. Sorry, as Councillor Kamali mentioned earlier on, where as a result of the pandemic and some of the economic challenges that have come as a result of it, home care agencies who are paying through us marginally above the London Living Wage, or at the London Living Wage, are competing with the retail sector, with the hospitality sector, who particularly around the kind of Christmas season and other festive seasons will offer golden handshakes, will offer higher salaries than that, which puts pressure on being able to retain people in the home care sector. So that we've seen a slight dip in recruitment and retention as a result of that. There is another element which is a challenge around workforce, but I'll come back to it if I may. On the points around the future design and how we've been engaging the public, our partners, those who are in receipt of home care, those who aren't at the moment but maybe in future. The team has been working over a number of months, and credit to them, during supporting the agencies with the pandemic response as well, with support from the Institute of Public Care at Oxford University, who have been helping us to facilitate a number of workshop sessions with people in receipt of home care, with home care agencies and staff, and with NHS partners and others, to explore exactly some of the things that have resulted in the description I've given you here about what people's preferences are, what's the appetite for expanding the local market, what's the appetite, particularly amongst people who are service users and their carers, to explore more digital solutions. There's still some work for us to do on that, and to perhaps talk to a wider audience than what has mostly been people who are service users and their families at present. If there's a gap, I'd say it's probably in being able to talk to enough people who aren't currently using the service but may have a view on how it's shaped in the future. We have done some questions through forgive me, I forget the name of it, but the survey group we've had access to as the council in terms of asking the citizen survey, and we may be able to make more use of that in future too. But so there are a number of pieces of work that have gone into informing where we are at the moment that will continue.
Okay, thank you. No follow-up. Councillor Atkinson, please.
Thank you. I've got 5 questions of increasing difficulty, and then I have a suggestion. The first one, you gave us the information about the block providers, but you didn't say anything about spot contract. Can you explain what a spot contract is and why we need them? Because it's still a fairly large amount of money. And then the other question you brought up was the churn retention, which you've identified as being a problem. Could you quantify how much of a problem it is? I mean, are we still getting huge turnover of staff? Is it a case that people take the job more or less out of desperation, and the second they can find a better job in Tesco's, they're off? So I would ask about the numbers and what we're going to do about it. And then I'm curious about the employment fair that we're doing, which I think is an excellent idea. But how does that work? If we find people locally and persuade them that they are qualified and would want to have a job in home care, do we then pass them on to the existing agencies? And I suppose the more difficult question I would ask is, it seems to me we got into terrible trouble by becoming over-dependent upon a few national agencies, and I'm delighted that you are now focusing on local quality assurance and weekly or monthly meetings. But I do wonder, I mean, have we looked at all about providing direct employment ourselves, going back to, because that would undoubtedly make it much easier for us to keep the quality up. And it seems to me if we're taking an awful lot of effort to identify suitable people and encourage them into it, then to hand them on to someone else seems not thinking it through. So I'll stop there and then I'll give you my suggestion.
Okay. Forgive me, I'm going to try and answer them in the order that I can remember them. So as for the care fair, which is something that we had hoped to do prior to the wave of Omicron, the intention really is that we're bringing stakeholders together really, along with the residents. So we're not there just to take people's names and numbers. The idea is that the home care providers as well as the care home providers will be there at the meeting, and they will be able to reach out directly to residents that are interested. I see our role alongside Councillor Folkes, who's sort of heading up from the economic development team, much more to be a role of sort of facilitation and to make sure that we're providing a really welcoming environment for people to come along and see what the opportunities may be. Obviously it's new, so I'm very keen to see how it goes and whether we do have people sort of then offered employment coming out of it. I'm hopeful that we will, not least because a number of the providers themselves need staff, so I'm hopeful they'll be looking to our residents to fill some of the gaps within the borough, or the potential gaps. As for sort of offering the care ourselves, I suppose that sort of falls back to a slightly more, and I suppose you won't be too surprised, but it'll be a slightly more ideological one as well, that we're not necessarily taking out the bins ourselves either, nor do we do the traffic ticketing ourselves. We go to businesses which are competent in the sector that can be challenged.
Our experience is that they haven't been, and they've let us down very badly in the past.
Well, the ones we currently have are all rated good by the CQC. Obviously, H&F have a slightly different issue there. I would hope that going forward we'll be able to expand the capacity in the network so that we're not afforded that issue. And I think, frankly, expanding the capacity and simply adding one more in the form of RBKC perhaps doesn't do very much when there are other operators which are available out there. And as for your query on, forgive me, I'm going through my mind, it was on the churn of staffing.
Yes.
I'm deferring to Gareth on that one as to exactly how many people we see through the door. Oh, and spot purchasing as well.
Thanks.
He's giving you the easy one.
Spot purchasing is something that we use to give ourselves some additional capacity where, although we have block contracts in place for people, organisations operating on a geographical patch, there are still times when a call comes through and they're not able to take the case. And so that's not a situation that we can tolerate. So in those situations, there are other agencies that exist in our borough, that exist in other boroughs, that we can call on.
More specialist agencies.
Sometimes more specialists, or sometimes it's just there aren't enough people in the existing block arrangements. An example of a specialist is where we work with one agency in particular that helps with hospital discharge arrangements. And so we often use those for spot because they have to be done very quickly. That's a particular area of challenge, I have to say, and if our colleagues from the Trust were here, I think they'd probably flag that too. But there are instances where spot purchase arrangements allow us to add capacity. I'd add that comes with a contract. It's not a block contract that says that you can anticipate X number of hours per year, but it does give the local authority assurance around terms and conditions, how people are being paid, registration, all those elements of quality too. So it's not as if there's a kind of wild west of spot purchasing going on and block patch arrangements. It is controlled, and 12 is a fairly modest number in comparison to other places I've been. On the question about retention and can we quantify it, and what's the sort of degree of depletion or kind of desperation on that. Can I offer to come back with you with specific numbers? I don't have that off the top of my head, I'm afraid, the degree of churn. if I could answer it in kind of generic terms, I'd say it's a mix of high and low. So as Councillor Kamali said at the outset, there are a lot of people for whom this is a vocation and are either doing it because it's local and convenient, or it's a job they love. Some we know do this as part of a pathway to other types of employment, and particularly people who might have come here from overseas with higher qualifications abroad that they can't yet use here. We know home care agencies and some of our care homes sponsor them for a while to work as care assistants whilst they're getting UK nursing qualifications or whatever that pathway might be. And so some of that contributes to churn as well. But if I could come back to you with an average annual figure from some of our agencies, I can.
Thank you.
I can do so.
If I can, Chair, if I can finish off my...
Sorry?
If I may, Chair, can
Okay, go ahead.
Finish off my questions? Though I am very suspicious of when people talk about vocations, because vocations has always seemed to me to be a euphemism for not paying people properly. I remember when nursing was supposed to be a vocation, when teachers are badly paid, that was called sticking with their vocation. So I would avoid the term vocation if you possibly can. I had one other question which I didn't answer. I think this is a very good report, by the way. I should have perhaps said that at the beginning. The one paragraph that I am disappointed with and don't understand is on para 5.13 about demographics. I find that rather confusing. Does it actually say that we expect all age groups to go up by 26% in the next 7 years, or are we thinking in particular that it will be the elderly population is forecast to increase? No, it does say all age groups, in which case, rather than talking about the whole population of the borough, I would be really interested in the forecast of what the elderly population is going to go up, because as Councillor Spalding had said, I mean, I think it is very significant in this borough. And this is why this committee is so important, because A, we spend the most money of the council, and B, actually the care of the elderly. Says I, who's terribly interested in children and education, it is care of the elderly which is more important in this borough. It's not necessary. Sorry, my suggestion is, I think this paper is so good that if you could tidy it up and take out the bits about the priority, about inoculations and whatnot, could we not present this to the council at the March 2nd meeting, because I'm sure there will be other councillors who would like to have an input at this stage.
Thank you.
I'm just going to sort of respond on the point about vocation and calling. I think what I'm trying to articulate is that we need to offer people an actual long-term career and make sure we don't just inadvertently, let's say, and again I've got to choose words carefully, but we don't want to inadvertently be taking advantage of people's natural caring nature, and we need to make sure that the care agencies that we use and the sort of economic conditions that we find ourselves in are fair, fundamentally, and I appreciate there's a very stark economic reality that's likely to attach such a statement, but that's just the reality where we are. We are a borough that will have a 26% ageing population, and it's not something we can shy away from, frankly, so we need to budget for it accordingly as well.
I would actually say that my idea of employing people directly ourselves is the best way that you could possibly do to guarantee against that, but you seem to have set your heart against that, irrespective of the situation.
I'm fully set on using the best people for the job, Councillor Atkinson, and that's it, and the best operators as well.
Maybe we'll take this out of the meeting.
Thank you very much. That's quite a good, honest answer, and thank you to Councillor Atkinson for these challenging points there.
So,
Councillor Spalding first.
Could we actually agree to send this paper to the council meeting?
Can we just listen to Councillor Spalding first, then we'll consider that. Yeah, thank you.
Thank you, Chairman. A year ago, we were very worried about care workers being a vector of infection and people being discharged from hospital into care settings. And so it's very good to see you've got 80%. So, well done. That's to be congratulated, because it was a concern 12 months ago. Thank you for that. it just occurred to me, you know, having done recruitment of students into further education, you have to incentivise why they would want to come to your institution. Having done this also in charity sector, chaired charities, where it's been difficult to recruit the best staff because the charity hasn't been able to afford the best wages. And this sector, this care sector, has always been historically underpaid. And I know you're talking about the London living wage, but I mean that's just that's a safety net. It's not really incentivising, and the problem is staff shortages and retaining staff. And so I wonder if, I mean, let's look at it from a market's view. We are competing with other boroughs to retain staff and get the best staff into our care system. Now, we might not want to do that, compete with other boroughs, or even compete with other countries by, you know, recruiting abroad. But if we want to enhance the careers of carers so that we retain them, it just occurred to me, on top of what they're paid by the care companies, as a borough, we could do a little bit to enhance our carers' experience, and not just in terms of money, but the other things we can offer as a borough. And then I thought these are a few ideas that we could add to make this borough good at looking after our care staff. We could offer them childcare, subsidised or even free. We could get them some sort of freedom pass so that they can move around the borough easily. And also, you know, that led me on to a couple of other thoughts. We might offer them driving lessons, and we might offer them car club membership during working hours, so they can get round their day's appointments. We could, the lead member, Councillor Kamali, mentioned key worker housing, and of course they should get up the list in eligibility for key worker housing. Certainly career path, we could offer them something in terms of further training and NVQs and vocational qualifications to enhance their own career path, make it a bit more professional, which we could pay for. You could think about retention bonuses. I mean, the best employers do for their key staff, and if these staff are in a shortage profession, they become very important. And then finally, we could do something like giving them digital access. We could give them a mobile phone contract whilst they're still in employment, and that would enhance their ability to be a digital advocate and also to communicate. I don't know if they have to have their own phone or if their employers offer them a phone, but these are all small things that would enhance their professionalism, but at the same time retain them. And it would be at minimal cost to us. So I don't know if you want to consider any of those ideas. Thank you.
Thank you, Councillor Pauling. In fact, I was having a conversation with Viz about this just, I think, a few days ago, about what other things could we sort of leverage, not necessarily at cost, but things sort of, you know, working in partnership with the museums to make sure that they could have, you know, access. You know, transport is obviously a key one. I think housing, to me, is the one that I'm very keen to explore, simply because you know, it is such a difficult issue in the cost of living in central London. We're fully aware of the cost of not only living in London, but also then getting to Kensington and Chelsea, for instance. So we are competing, and right, I think competing is the correct term, with boroughs which are perhaps closer to where they live. You know, so we have to offer that extra reason to want to come to Kensington and Chelsea. I think a lot of what you're mentioning are probably things that could be looked at within the framework of any contract with the companies. You know, I really, as I say again, these not all will be free, and not everything is going to come to us freely. I think we do have to really look at where the market is going. I'm sure Gareth, I mean, he absolutely is, and make sure that we are offering competitive wages, but also benefits that perhaps other boroughs can't, and we have to sort of leverage our very unique situation, proximity to the West End, the by-borough arrangement with theatres, etc., just see exactly what we could do that perhaps sets us apart from other areas.
Thank you, Councillor Kamali. That's really good. Councillor Williams, do you want?
No, wait. Okay. Thank you, Chairman. Yes, firstly, I'm afraid I must disagree with Councillor Atkinson on directly employing care workers. We did this some years ago and it didn't work out very well in the end. And I think what the important thing is to pay a competitive salary. And if you employ them directly, you have to pay the local government pension scheme as well, which I think people in that situation might not fully value. They just look at the bottom line. So, I mean, that's not something I would favour. However, I was interested in the proposal to be able to enable the agencies to offer guaranteed hours, possibly even full-time employment. I just wonder, I suspect some of our neighbouring boroughs are able to do this already. Is that correct? Because Health Vision, I see, was offering full-time care worker positions, although that suggestion seemed to be, I may be wrong, that this was actually for people to work in Brent. So this seems something that would be useful to offer. Some people want it, some people may not.
I don't know that, so I'm looking to Gareth on that one, but very interesting.
Yeah, that's true. Some boroughs have offered that as a contract. The challenge, as you point out in the question, is uptake of it. A colleague in our team who manages our brokerage service previously has been the manager for many years of different home care agencies, so understands that part of the market very well, and says to me regularly, I couldn't give those contracts away to staff that I wanted to come and work for me. I couldn't get staff to come and work on a 37-hour-a-week contract because they wanted the flexibility. And that's not true of everybody, which is why we want to pursue the opportunity of this, and clearly it is happening in some instances. But it's not as if it's something that local authorities aren't offering, but everybody wants. There's a economic tension there.
There's a kind of trade-off there. Thank you. Christine, do you want to? No? Okay. Now can I open the questions to Councillor Healy, please.
Thank you, Chair. I'd like to, I do think there are some very positive things in this report, particularly the idea that my home care is now rated as good by the CQC, given that it's not so long ago they came very near to losing their contract with us. But I'm interested in what's happening at Sage Care. Can we know how many Kensington and Chelsea residents are actually covered by their provision, and whether or not there is a new date for their being inspected? I'd also like to touch on staffing issues. I find it very difficult to believe that anybody who is doing home care work wants to have a 0 hours contract. They may want flexibility in terms of being able to work part-time because of their own family commitments, but a 0 hours contract means that they don't know how much they're going to earn in a particular week, and given that the money is already, compared to other jobs, fairly low, I find it very difficult to believe that, and I do hope that we do get rid of it as soon as possible.
Thank you for the questions. On the point about the numbers and the date for the re-inspection of Sage Care, Chair, with your permission, can I come back with those, because I don't have them to hand, but I will make sure that they're brought to you. On the point about 0 hours contracts, I do take the point. I mean, one of the other areas that we are keen to see an increase on, which would address that, and kind of shouldn't lose, I guess, in the discussion about the agencies, is direct payments. And I think that also comes to the point about employing people directly, because one of the things that direct payments enables is that degree of personalisation, where somebody has a choice about who their personal assistant is, who they employ directly, so not necessarily through the local authority, through an agency, but through themselves directly. That's a particularly cost-effective option, but it also enables that individual to choose to a degree, how much they would like to spend on an individual. So one way of trying to address the challenge around block contract hours versus activity hours or 0 hours contracts is continuing our work to try and increase the proportion of people who are accessing their care through a direct payment, because then they can make that choice themselves.
Thank you. Any other question from the public? No? All right. Thank you very much. We had extensive debate on this, and thank you for your input into this item. As we can see, it's a quite highly sensitive issue, as being highlighted, and Councillor Atkinson's recommendation to bring this to the next full council meeting, I think I'm happy to discuss it and have the agreement of the committee if possible, so we'll do it by email, not now. Thank you, Councillor Atkinson, for that suggestion, which I really welcome. Now we move to item A6, verbal COVID epidemiology update. So we have a brief verbal update from Anna Raleigh, Director of Public Health. Please, over to you.
Thank you, Chair. So some of the key lines I'll share with you first, and then I'll just take you very quickly through some of the data and explain the different timeframes I'm talking about. So overall, the current wave, this fourth wave of the pandemic, peaked between Christmas and the New Year. Following this, we've plateaued at quite a high rate. However, there is some indication that we now may be starting to see a downward trend. Throughout this period, deaths and hospitalizations have remained relatively low as well in comparison to some of the challenges that we had earlier on within the pandemic. Since the start of the pandemic within RBKC, we've had 36,805 cases, and in terms of deaths, we've had 320 people who've died with COVID on their death certificate, and that equates to 271 who died within 28 days of a positive test. I'm going to share a data set with you now, which is from Thursday last week, which is the last most complete data set that I have. Within RBKC, to make comparisons across the week, our case rate per 100,000 was 850.4 per 100,000, which equates with the London case rate of 922.4 and an England case rate of 1,082. So that equated to the 17th lowest case rate in London. Case rates at this point are highest in the west of the city, with the highest rates being in Richmond upon Thames at 1,385 per 100,000 for comparison. Our 60 plus case rates is the case rate that we monitor very carefully, and that case rate is currently at 350.9 per 100,000, and that was a 3% decrease from the previous week. Case rates remain highest in the primary school aged population and across the board in the 5 to 19-year-old age group. Again, this is what we're currently seeing in terms of outbreak management, the population and the group that at this stage we are most focused on, that primary school age group. You'll be aware that there have been some changes to testing and how data is collated. So people no longer need to confirm their LFT test with a confirmatory PCR, and also confirmation of the LFT test is something an individual does using an app over the telephone or their computer. So what we're starting to see at the moment is a comparison across those case rates which I've traditionally reported to you, the ones I've just gone through, and also the ONS population survey. There's good read across still between those case rates and the ONS population survey, And what the ONS population survey tells us is that the percentage of people testing positive for coronavirus has remained high in the week ending the 29th of January, and they're estimating that about 1 in 20 people are testing positive for COVID. And again, we're also seeing highest in the aged 2 to year 6, which is the primary school age population group, and it's lowest for those aged 70 and over. So again, a read across with what we're seeing locally in our data as well. Our positivity rate is at 11.3 per 100,000, so that means out of all those who tested, 11.3%, apologies, 11.3% tested positive. Bringing you on to this morning's update, we've observed a slight increase moving on to this morning's data. So the RBKC case rate per 100,000 is now 785 per 100,000 as of this morning. Happy to take any questions or queries or anything that councillors would like me to expand upon.
Okay, thank you very much, Anna. It's appreciated, and I'm glad there is a low admission rate at the moment, so that means the impact is not as severe as now what we experienced before. I will open now to the committee members. Councillor Addenbrook, then Councillor Williams, please.
Thank you, Anna. Just a quick question. Are we seeing any of the Omicron subvariant BA2 here? Or?
Across London as a whole now we are starting to see an increase in BA2, and it may well be that BA2 will move on and start to outperform BA1, which is what the current Omicron variant is known as. There are no current concerns around that because essentially we're seeing a similar profile in terms of the severity of disease and also in terms of vaccine evasion. So we're monitoring that, but there are no concerns at this point.
Thank you. Councillor Williams?
Yes, I mean, just a sort of observation that Professor Tim Spector says from his Zoe study that in fact there appears to be significant underreporting of positive lateral flow tests, and that in fact we're going to see an uptick probably in the next week or two from the ONS figures, but still with low hospitalizations. But I really wanted to ask about testing, and in particular the availability of PCR tests. So, I mean, when would people be taking PCR tests, and are we still providing the facility here in the mobile unit?
So at this point in time, the message is that if you have a positive LFT test, at this point, because of pressure that was on the system for testing, you don't need to confirm that with a PCR test. You can take it that your PCR test would come out positive. So that's currently what people are working towards within the system at the moment. At the moment, in terms of our testing availability, we currently have 2 MTUs within Kensington and Chelsea, which are providing PCR testing available for people. So they are available at Kensington Town Hall and also at the World Ends Estate. They are operating 7 days per week between the hours of 9 and 4 p.m. So we've got quite good capacity in terms of PCR tests. We're also continuing to offer asymptomatic testing at the town hall here, Mondays to Fridays as well, for members of our population who want to come forward too. Home tests are also provided to food banks, libraries, community venues, bridging hotels, etc., to increase better reach into our populations, particularly some of those underrepresented groups and some of the disproportionately impacted groups.
Yes, I thought, who are the PCR tests for then? if you test positive through a lateral flow test, you're told you don't need to do one. So who are they for?
Ultimately, people who are undertaking an LFT test, a lateral flow test, they will be people who don't have any symptoms. So people who are going forward for a PCR test will be people who have symptoms. So if people start to have a symptom, then they will go forward and they will have their PCR test.
Thank you. That's encouraging, very clear. Okay, I would now invite councillors who are not members of the committee wish to ask questions to speak, please. No? Any members of the public? No, it's here, no? All right. So thank you very much, Anna, for this update, and it's greatly appreciated. And thank you for all the work you are doing for our community here. We'll appreciate that. And now, we thank you for all of your contribution. Now, the final items, it's the very brief, I hope. It's going to be item A7, the Select Committee Work Program. And this is the final item on the agenda for the program tonight. May I call James Diamond, please? He's our Scrutiny and Policy Officer, to introduce the report, please.
Thanks, Chair. So the report just sets out the remaining agenda for your final meeting of the year, which will be on the 3rd of March. I did note the discussion among committee members earlier. So if it's the resolution of the committee that you want to have an item on palliative care review and Pembridge, please indicate and we can put that into effect. Thank you.
Okay, thank you very much. That's taking care. Any member of the committee would like to ask a question? Yes, definitely. Thank you. Yes, definitely. That's a wish of the committee, I believe, and I totally agree. So we'll work together, James, on that. Thank you, members. Now, item A8. Any other oral or written items that's being considered urgent? I haven't received any urgent matters. So for this reason now, I'm really grateful to all of you, my committee members' support, and the every officer's contributed to tonight's discussion. I will conclude here this meeting, and thank you very much, and very good night to you.